Hello students, it's Dr.Ahmad Jami and we are discussing about ascites. As we are covering about liver pathologies, our next topic is ascites. So we are going to touch the definition. What is ascites? Ascites is abnormal accumulation of fluid within peritoneal cavity. And it's a common complication of portal hypertension. You got it? And the second common complication is hypoalbuminemia. So you are going to define as abnormal accumulation of fluid within the peritoneal cavity, which is commonly caused by portal hypertension and hypoalbuminemia. So what causes portal hypertension? Liver cirrhosis, we have discussed in detail in liver cirrhosis lecture, and acute liver failure. And what causes hypoalbuminemia? Kidney abnormality, nephrotic syndrome, in which there is more than 3 gram per deciliter loss of proteins from the body, nephrotic syndrome. So that's the definition we have covered so far, and now we are going to discuss about its etiology. What are the causes of ascites? First one is portal hypertension. What causes portal hypertension? Cirrhosis, liver mets, Budd-Chiari syndrome, in which the hepatic vein obstructs. Next thing is right heart failure, also causes portal hypertension. And the last one is portal vein thrombosis. A thrombosed particle obstructs portal vein, leading to portal hypertension. So the next cause we are going to discuss is hypoalbuminemia. Which factors and which diseases causes hypoalbuminemia? First one is nephrotic syndrome. Second one, malnutrition. Patient is taking protein in less amount, or patient is having absorption dysfunctions. Patient having protein losing enteropathy, absorption problem. Next thing which causes hypoalbuminemia, acute or chronic hepatic failure. So the third factor which leads to ascites is malignancy. We are going to discuss about those malignancies which causes ascites. First is, as this ascites is abnormal accumulation of fluid within peritoneal cavity, any carcinoma of peritoneum can also cause ascites, peritoneal carcinomatosis, especially from ovarian, breast, bronchi, gastric, pancreas, and colorectal. These carcinomas, if metastasis to peritoneal cavity, can lead to peritoneal carcinomatosis, carcinomatosis and leads to ascites. Next thing is lymphomas with peritoneal involvement. The third cause is liver metastasis. Liver metastasis. Now the fourth point we are going to discuss about ascites risk factor is infections. Infections. What infections can cause ascites? TB can cause ascites. Serositis can cause ascites. And the last one we are going to discuss is pancreatitis. These are the risk factors associated with or causing ascites. The next thing is, what is the pathophysiology? As a medicine student, you should know about the pathophysiology of all these risk factors, but you will find it non-serious, so you can ignore it or you can understand it. It should be in your mind for a better clinical review. So we are going to discuss about pathophysiology. So we are going to revise it in a very fast way, that how portal hypertension leads to ascites. Let's see portal hypertension. How portal hypertension. In portal hypertension, there is increased hydrostatic pressure in portal vein. In portal vein and its tributaries. This hydrostatic pressure is increased hydrostatic pressure in splanchnic and peritoneal cavities. Splanchnic and peritoneal capillaries. Increased hydrostatic pressure in splanchnic and peritoneal capillaries leads to fluid transudate. Transudation leads to fluid transudation from serosa of GI tract and peritoneum. This fluid transudation leads to accumulation of fluid in the peritoneal cavity, and this leads to ascites. The next mechanism is increased hydrostatic pressure in hepatic sinusoids. In hepatic sinusoids leads to increase in hydrostatic pressure in hepatic lymphatic vessels. This increase hepatic pressure, hydrostatic pressure in hepatic lymphatic vessels leads to fluid transudation from liver surface, which leads to ascites. So next our cause was hypoalbuminemia. How hypoalbuminemia leads to ascites? We are going to discuss it. The pathophysiology of hypoalbuminemia. There in hypoalbuminemia, as you all know, that proteins tend to bind the fluid molecules along with it. In a low albumin count, there is decreased intravascular colloid osmotic pressure. Colloid osmotic pressure is reduced in a case of hypoalbuminemia, which leads to fluid transudation. Low protein molecules, low binding with fluid or fluid components, so fluid will transudate outside from intravascular to peritoneal space, and accumulation of fluid in peritoneal space is called ascites, peritoneal space. So next we are going to discuss is malignancy? How malignancy is associated with ascites? How, what is the pathophysiology of malignancy? In peritoneal carcinomatosis, there is blockage of lymphatic vessels. As the lymphatic channels and lymphatic vessels are blocked, there is increased capillary permeability. Permeability means there is increased flow of fluid inside outside the capillaries vessels. This is the capillary vessels. Here goes the fluid. Here goes the fluid. It comes more permeable. So this leads to accumulation of fluid which is protein rich. Accumulation protein rich fluid in peritoneal cavity. In peritoneal cavity. This protein rich fluid in peritoneal cavity accumulation leads to ascites. So next malignancy we have discussed is lymphomas. What is the pathophysiology of a lymphoma leading to metastasis? A lymphoma leads to obstruction of, it also causes obstruction of lymphatics. Which lymphatics? Which are those lymphatics which are retroperitoneal, present behind the peritoneum. Obstruction of lymphatic vessels which are retroperitoneal and leads to accumulation of chyle, chyle, chylous ascites. Such ascites is called chylous ascites. We are going to discuss types of ascites in our later section of this videos. Now the fourth thing we are going to discuss is how infection leads to accumulation of fluid in our peritoneal cavity. In tuberculosis, there is formation of tubercles which are located on peritoneum. These tubercles produce protein-rich fluid in peritoneal cavity, and this leads to ascites. Now the last our risk factor is pancreatitis. How pancreatitis? What is the mechanism of pancreatitis leading to ascites? In pancreatitis, there is leakage of pancreatic enzymes. Which enzymes? Pancreatic enzymes. Where they leak? In peritoneal cavity. This leads to inflammation of peritoneum. Peritoneal inflammation. This inflammation leads to increased vascular permeability. As you know, there is increased vascular permeability. There is accumulation of protein-rich fluid. As protein-rich fluid accumulates, this is the ascites. Accumulation in peritoneal cavity, and this leads to, and this is ascites. You got it? So we have discussed so far the pathophysiology of ascites, what different risk factors are causing and how these risk factors are causing. So our next discussion is about clinical features, how a patient presents. Clinical features, how a patient presents. The first thing is, as definition declares, accumulation of fluid in peritoneal cavity. There will be abdominal distension. Abdominal distension. This abdominal distension includes as there is increased intraperitoneal pressure, patient have weight gain, early satiety, dyspnea, and you are graduate enough to understand why patient develops dyspnea and diarrhea. If patient is of chronic ascites, patient presents with diarrhea in chronic cases due to malnutrition. The next sign we are going to observe in an ascitic patient is flank dullness. When flank dullness presents, when there is more than 1.5 liter of fluid, ascitic fluid in peritoneal cavity, more than 1.5 liter of ascitic fluid in peritoneal cavity will find flank dullness. The next thing we are going to observe in our abdominal examination is shifting dullness. What happens in shifting dullness? Patient is lying supine. We try to tap on one side of his abdomen and observe what we feel on the opposite side of abdomen. If a patient is lying supine, you will find dullness, dull resonance in an ascitic patient. Now you shift the patient into lateral cubitus position. Lateral cubitus position. What will you find? You will find tympanic resonance. These are the clinical findings of ascitic patient. Next thing you are going to test in ascitic patient is fluid wave test. No teacher told us about fluid wave test. Uh, what is fluid wave test? In fluid wave test, a wave is produced when we tap on one side of the abdomen in a patient in a supine position. This wave is transmitted to the other side via ascitic fluid. So what it indicates? It indicates the liver is enlarged, hepatomegaly. So fluid wave test can be positive in hepatomegaly. In ascitic patient we can also find jaundice. What else we can find? We can find in simple the signs of liver cirrhosis, spider angiomata, palmar erythema, or signs of chronic liver disease. So what are the subtypes and variants of ascites, a patient with ascites? As I discussed, patient can have chylous ascites. The next thing is hemorrhagic. Hemorrhagic. Third one is pancreatic. So in what happens in chylous ascites? In chylous ascites there is a accumulation of lymph in peritoneal cavity which is rich in triglyceride and has a milky appearance. Just remember these 2 points. Accumulation of lymph in peritoneal cavity or abdominal cavity which is of milky color or milky appearance. In which conditions chylous ascites is present? In lymphomas, malignancy, hepatic cirrhosis or other lymph node disorders. in which there is increased production of lymph fluid, there can be chylous ascites. Next type is hemorrhagic ascites. Ascitic fluid, when we are going to examine the ascitic fluid or ascitic tap, we going to culture it or analysis about it, what is present in this fluid, the composition of ascitic fluid. So if there is more than 50,000 millimeter cube of RBC is present in ascitic fluid, we'll label it as hemorrhagic, and its etiology may be spontaneous due to peritoneal carcinomatosis or a malignant mass eroding any vessels, which leads to hemorrhage of that vessel into peritoneal cavity or abdominal cavity. The next, our subtype of ascites is pancreatitis. When there is accumulation of pancreatic fluid in ascitic fluid, accumulation of pancreatic fluid in peritoneal cavity, we label it as pancreatic ascites. What is the criteria? If there is more than 1000 international unit per liter of serum amylase level in peritoneal tap or peritoneal analysis, fluid analysis, if there is more than 1000 international unit per liter of serum amylase level, we label it as pancreatic ascites, and our causating factor is pancreas. So next going to discuss is diagnosis, how we will diagnose a patient. In a very easy way, I am going to tell you the diagnosis of how we will go and proceed for the diagnosis of ascites. First test we are going to perform is abdominal ultrasound. What we will find in abdominal ultrasound? Free intraperitoneal fluid. So next thing is CT abdomen. I am trying to shorten my video, so I am not explaining everything in a very clear way. So after CT abdomen, what will we find? Same finding, free intraperitoneal fluid in case of ascites, and in CT abdomen, fluid density will tell us what kind of fluid is present, whether it is pancreatic, hemorrhagic or chylous. So next, our diagnosis is laboratories, lab diagnosis. What will we examine? We will see CBC. If there is liver cirrhosis, we will find thrombocytopenia as well as coagulopathy. We have to rule out the cause, which we'll discuss. Next thing, we'll go for coagulation profile, whether liver cirrhosis is advanced or not. Next thing we are going to study is liver chemistry. In liver chemistry, we will study about transaminases, which will be elevated, which suggest liver diseases. Next thing we will go to study in liver chemistry is serum albumin level. For calculation, we will study SAG concentric SAG calculation. Next test is basic metabolic panel for our electrolytes, creatinine and blood urea nitrogen. Creatinine and blood urea, if either there is any acute kidney injury or not. A patient having decompensated liver disease are more commonly develop acute kidney injury, so their creatinine and blood urea nitrogen is elevated in such patient. We will study serum electrolytes in acute kidney injury. So serum electrolytes we will going to study about whether the volume is normal or not. Hypovolemia, we will see hypotonia, hypotonic, hyponatremia. This is the complication of cirrhosis. Liver cirrhosis. So what we are going to proceed in our next lab diagnosis is ascitic fluid analysis. Sampling, how will take sample? We will go for paracentesis. The aspiration of small amount of fluid or small volume of fluid from the peritoneum just to diagnose or to check the nature of peritoneal fluid. This procedure is called paracentesis and it is diagnostic as well as therapeutic. In diagnostic, we will take a very small volume. In therapeutic, just to relieve the symptoms of high fluid volume, we will take amount of high volume of ascitic fluid. So all the patient which develops new onset ascites will go for diagnostic ascites and diagnostic ascitic fluid analysis. So what will we see in our peritoneal fluid analysis? We will see the gross appearance of fluid. Let's discuss is if it's yellow or transparent, it means uncomplicated ascites. If it's cloudy, what's the color of cloud? If it's cloudy, it shows infection or malignancy. If it's bloody, what it shows? Hemorrhagic trauma, or in case of malignancy, if it invades blood vessels. In if it's of milky appearance, what will you indicate? It indicates chylous ascites. And in case of dark brown appearance, it indicates the bile leaks into peritoneal fluid, biliary leakage. There is a gallbladder perforation. So next thing we are going to study in peritoneal fluid analysis is cell count and differential. What kind of cells we are going to discuss here is neutrophils, if there is more than 250 cells per millimeter cube in the fluid, it indicates spontaneous bacterial peritonitis, that peritoneal cavity is infected by bacteria. So next thing we are going to study in ascitic fluid analysis is SAG, SAAG, SAG, not the SAG in Punjab. Serum ascites albumin gradient. In this test we are going to use this test to differentiate between ascites due to portal hypertension or non-portal hypertension. In what causes portal hypertension we have discussed in detail in this lecture. in start. So we are not going to discuss. So what are the findings? SAG indicates albumin level in serum, and we are going to take the ratio SA over AD. It means serum albumin level in serum divided by albumin level in ascitic fluid. If its value is more than 1.1 gram per deciliter, it means high SAG value, SWG, high SAG ascites. It indicates portal hypertension. If its value is less than 1.1 gram per deciliter, it indicates non-portal hypertensive ascites. Non-portal hypertensive ascites. If less than 1.1, it means low SAG ascites. So we'll check ascitic fluid albumin concentration and ascitic fluid total protein concentration to differentiate about our different risk factors. If there is high ascitic, let's pose the specific test for ruling out cause of ascitic fluid from cardiac causes or hepatic causes. We take ascitic fluid total protein concentration. Why we are doing this ascitic fluid total protein test? To differentiate between hepatic and cardiac causes. And in both these causes there is high SAG concentration, means there is more than 1.1 gram per deciliter of albumin in serum. So next thing we're going to study about it is microbiology to rule out any infection. We'll gram stain this ascitic fluid. We'll culture the ascitic fluid. We're going to study about spontaneous bacterial peritonitis from secondary spontaneous peritonitis. We'll study about LDH, glucose level in ascitic fluid. We're going to check for whether it's tuberculous or not. We are going to perform acid fast bacilli test, smear test. You are getting it. If there is any suspected malignancy like peritoneal carcinomatosis, we'll go for cytology of fluid. We'll go for tumor markers. If there is CA125 antigen test, cancer antigen 125, we can perform CA125 antigen test. In most cases it is raised without knowing the cause. Next thing is CEA. We are discussing about the markers in those patients which are having gastric and intestinal adenocarcinoma. Gastric and adenocarcinoma of intestine, CEA may be elevated. So this is all the laboratory findings and suspected findings we can find in an ascitic fluid analysis. The next thing we are going to study is treatment. How will we treat? The very crucial part of our lecture is how will we proceed for treatment. First of all, we'll approach the patient and try to find the underlying cause and condition, and we'll rule out and treat the cause. Treat the cause. Let's So next thing, there is huge abdominal distension. Huge distension. What will we do? We'll do therapeutic paracentesis for large distension and for large ascites. In those patients which presents, if a patient comes to you with abdominal distension and having a history of liver cirrhosis, what will you do? We'll treat liver cirrhosis. We'll consult him, we'll advise him to avoid NSAIDs, ACE inhibitors, we'll restrict sodium diet, as well as sodium restrict, will advise the patient not to take any salts. And next thing we are going to say is take diuretics. What kind of diuretics? We are going to give diuretics, as well as we can give furosemide to such patient. So the main treatment plan is of cirrhosis is ascitic fluid cirrhosis patient is liver transplantation, as you all know. So the main treatment of cirrhotic liver is liver transplantation, but we'll advise and cure liver cirrhosis, and we'll restrict his sodium diet and give him diuretics. If a patient comes with non-cirrhotic cause of ascites, non-cirrhotic cause, what we will do? We'll do like patient is having underlying malignancy, metastasis or malignancy, we'll advise surgery. Let's suppose patient comes with heart failure, we'll treat heart failure. And if patient comes with tuberculosis ascites, we'll give him anti-tuberculous therapy. So what is the main medical and sportive therapy? First step is salt and fluid restriction. As there is accumulation of fluid, we will restrict his salt, especially sodium, and fluid levels. Fluid restriction. We will advise him not to take more than 2 grams per day sodium daily, and will restrict his sodium intake by only 1 liter per day. In a case if will in only those cases where sodium concentration is where sodium is less than 125 milliequivalent per liter. So the next treatment we are going to give is diuretics. Diuretics. These drugs induces increased production of urine. So greater the urine, greater will be loss of fluid from the body. There is more relief of ascitic fluid or abdominal distension. We can give monotherapy or a combination therapy. In monotherapy, we will give only spironolactone, and in combination therapy, as I already discussed, we can give spironolactone plus furosemide. In those patients where we want fast results, we will give, or in hospitalized patient, we will give spironolactone plus furosemide. Or in those patients where large amount of ascitic fluid is present, there is huge abdominal distension, we will give a combination therapy. So next thing is you try to give therapy. Now the fluid is already present there, How to relieve more fastly? We'll do therapeutic paracentesis. In diagnostic, we'll take less volume of cytic fluid. In therapeutic paracentesis, we'll take large volume of fluid from the peritoneum. So we perform it under ultrasound. So if a patient comes to you with refractory ascites, how will you treat or manage it? You know that last week patient developed, 2 weeks ago patient developed ascites. Now he is presenting with again ascites. We'll rule out the cause that patient whether is taking diuretic in confined dose which is suitable for him. We'll check dosage of diuretics. We'll optimize medications. We'll perform large volume paracentesis along with infusion of albumin, IV albumin infusion plus therapeutic paracentesis. We'll evaluate for invasive management options like TIPS, transjugular intrahepatic portosystemic shunt, or we'll evaluate whether we need liver transplant or not. That's all for ascites. Now the last thing we are going to discuss is complications arising from ascites. As you all know that accumulation of fluid leads to pressure inside the abdomen and outside the abdomen. Like a distended abdomen exerts pressure on skin. So what will patient can develop abdominal wall hernias. What kind of hernias patient can be presented with? Umbilical, inguinal or inguinal or incisional hernias. Next thing patient can develop as a complication of ascites is spontaneous bacterial peritonitis. The fluid can accumulate bacteria or can be infected with bacteria and leads to spontaneous bacterial peritonitis. Next thing patient can present with cirrhosis complication. What were the cirrhosis complications? Portal hypertension complication, esophageal varices or upper GI bleed, hepatorenal syndrome, hyponatremia, or cirrhosis, cardiopulmonary complications of cirrhosis leads to hepatopulmonary syndrome, portopulmonary hypertension, hepatic hydrothorax, or there can be hemostatic abnormalities like coagulopathies, increased bleeding risk, coagulopathy, and portal vein thrombosis. In cirrhosis complication, there are many complications. I discussed like metabolic complications can arise, leads to hepatic encephalopathy. Patient can develop jaundice, secondary hyperparathyroidism due to reduced enzyme activation of vitamin D. Next thing, it can affect adrenal glands. Adrenal insufficiency is also a complication of liver cirrhosis. Liver abscess can develop secondary diabetes mellitus, and also nutritional deficiencies can develop in a cirrhosis patient. And the most lethal complication of cirrhosis is hepatocellular carcinoma. So that's all cirrhosis complication you have listened. That's all for ascites. If you have any question, you can ask.